So just before I invite Dr. Shyam, I would like to also add one important point about US FDA approvals. We always assume that it is they are trying to favor the pharma industry, but let us not forget that there is a very strong patient lobby that is also influencing that. Okay, having said that, we are now ready for the breast cancer session, and may I invite our chairperson Shyam to start the ball rolling.
Thank you for this opportunity, invitation, and for this such an important session, which is actually going to be discussing two path-breaking abstracts in the field of HER2 positive. So I think Dr. Sudeep did mention Dennis Lemon. So I think he is the guy who really brought in the understanding of Trastuzumab in patients with HER2 positive breast cancer. And now the thought is that after we've got such two, antibodies, Pertuzumab and Trastuzumab with chemo, we have two important combinations, which are actually competing. Let me put it this way at this point in time, but the experts are going to tell us whether it is the DXD or it is the Tucatinib. And then you have the HER2 climb 02 also knocking on the door, which, I think maybe Randeep is going to talking about. I think kindly come over. I think I don't want to stay between you and the experts and the audience here, because these are really, really important studies, and we have the drugs available. If not, I think the second one is going to be available very soon for us to use. So I think over to Randeep. So. Yeah.
Thank you, Shyam sir, and congratulations to Dr. Amish and Dr. Purvish sir to making this one of the sought after meeting. I mean, one of the Indian oncologists look upon. I think I have a very learned panel, Dr. Safalta, Dr. Indu, Dr. Hemant Malhotra sir, Dr. Sekhar, Dr. Amol, Dr. Senthil, and Dr. Krupa Bajaj. Okay, so while as the panelists and the settling in, there are two papers. I will be covering HER2 Climb, the original paper, which was NEGM 2021, and then the final overall analysis, which is March 2022. So both the papers are discussed, the original paper as well as the HER2 Climb, updated OS, and the Lancet Oncology single paper, which is on DB03. To just start, the HER2 positivity, this is Indian data, which is very varied, 26 to 50%. There are significant ethnic disparities, and we do agree among not even Asian, non-Asian, Caucasian, but also we have to remember that ER positive, HER2 positive and ER negative HER2 positive are not same. As we talk about these higher molecules, we have to remember this data from TMH, which reminds me that it was 8.6% usage of Trastuzumab a decade before, sir, and now Nita Nair, Nair is N Nair, Nita Nair et al., their usage has shown 57%. So this is the reality. But unfortunately, when we stand in these meetings, we have to keep cost apart. If all the panelists agree, I think both the trials are practice changing, because the Amish is there. I think they agree. There is no comment about that. The difference is that how these trials will change our algorithm. And I remember Ullas' last slide that after ESMO 2023, whether treating HER2 positive breast cancer is easier or difficult. And for the discussion sake, we presume that pockets are very deep, and we presume that Tucatinib is also available to the Indian population. We will come to the last slide for the practical use. Everyone's pockets. Okay, so we'll start with Senthil and then go towards this side. And we will, so life was simple, 2022.
But I was ready.
Dr. Senthil,
yes,
how will you treat a patient in 2020-21? Are you agree with either of these comments on the algorithm? Very brief comments. Forget, there was no Tucatinib, there was no TDX, there was no Neratinib, there was no Margetuximab. So how you were treating it? And we presume that after THP, patient had brain mets and not brain mets. So very brief, and I want comments from all, because that sets that how were we using it and now what we will do forward after the trials.
So sequence number 1 is what we follow now.
Okay, and if THP with brain mets, without brain mets?
So if it is active CNS metastasis, then what we would do is we would do radiation, which would be whole brain or SBRT to the brain metastasis, and then do,
sequence 1 or sequence 2?
In the brain, you continue the same. If it's systemic progression also, you radiate and change. But the sequence will remain what is,
sequence 1 or sequence 2?
Sequence 1.
With brain mets, without brain mets? Both.
Irrespective, we'll treat the brain and continue the same.
Fine, perfect. Hemant Malhotra sir? With brain mets, without, both comments. Sequence 1, sequence 2.
Yeah, I think what Senthil is saying, I would agree with that. And in addition, if there are symptomatic brain mets, then we would address them. Few of them, SBRT, a lot of them, then whole brain RT.
And
But
sequence
the
1, sir?
Sequence 1 would be there.
Okay, fine.
With or without CNS.
Fine.
Can I go back?
Achha, you want me to go back?
Yeah.
There is no
Please,
sequence
please.
3.
No, there is no
I have to
sequence
cut
3.
it short. No sequence
No,
3.
listen. Please remember that we have kept capecitabine and lapatinib, LabCap, as the part of the sequence. And when you discuss the Tucatinib trial, we should remember that we have a LabCap option.
I remember that. That's why I've kept it. The whole idea of the control arm of Tucatinib, I've kept that. That's why I think you have not told the answer. What is your sequence? 1 or 2?
The best.
Perfect. Dr. Sekhri?
One is
With brain, without brain mets. Safalta?
in both the setting. I prefer one.
Same, sequence 1. Wow, we have unanimously sequence 1. Perfect. Dr. Indu, any concerns about sequence 1? The medical oncologist wants to use.
You have not incorporated radiation at all.
It is already there. Senthil has said that. You were there in the panel, means Dr. Senthil has said that. Sir, I will just take your comments. And Dr. Krupa, sequence 1.
Sequence 1.
Senthil, you are the influencer. Amol and Senthil, they are the biggest influencer there. Okay, I'm just pulling their leg. Yes, sir.
So Randeep, in 2021,
Yes, sir.
we would irradiate symptomatic or asymptomatic both.
Brain mets. Okay,
Because
fine.
TDM1 and LabCap are, not drugs to really take care of the brain thing.
Agreed, sir. Agreed. And they have incorporated that. So, I think we all know that 8-year survival data, 7 years, or 8 years, 8-year survival data of Cleopatra was out. And 5 years, 37. Yes.
Leptomeningeal disease during that time.
We will discuss, we will keep that for the time. I know that is a difficult disease that was actually not included in these two trials. For the discussion sake, we will bring it later when we discuss brain mets. But in both the trials, the leptomeningeal were not there, or they had not specified. Mostly, it was an exclusion criteria. So this is what we had achieved in 2021, an 8-year survival of 37%. And we also know that TDM1 was superior to LabCap in the phase 3 trial of Emilia. So we all are aware of this, that this is what we have achieved. Now what I will do is, we will keep it very simple and not complex. We will start with methodology, how we read the paper, the clinical trial design and comments, the baseline characteristics and comments. I am weak in statistics, so I have skipped that. And I admit that, but Sudeep sir can make a comment if statistics are there, sir. And then we go to the results, PFS, OS, and then toxicity, and then conclusion. Okay. So this is the clinical trial design. I think, we will give you a chance. Dr. Amoli wanted to make a comment. We will start with you. Any concerns about the clinical trial design of HER2
So of course the concern
Positive
is
points, negative points.
the concern is with the control arm.
Achha, what did you want the control arm?
And as we have shown in our own flowchart in the first,
Yes.
that lapatinib and plus capecitabine should have been considered in
So
the
as
control
per
arm.
you, the
Plus-
trial should have
plus-
been, just let me speak, I am the moderator here.
Okay.
As per you, the trial should have, what was the control arm? You want a LabCap with Trastuzumab? I'm just asking that.
LabCap plus trastuzumab should have been considered. Plus, other thing that I want to ask is that
Yes.
prior treatment with trastuzumab, pertuzumab, TDM1 is done. Who uses again the trastuzumab once?
We all use it. Come on, Dr. Amol, when the
Unless
trial,
and
when the
until you
drug was
have-
not available.
Unless and until you have lapatinib in that.
No, when the
Generally, in
trial,
our practice, we'll use LabCap.
okay, fine, agreed.
There is a
But,
trial which
but no
should
one can
continue.
deny the statement that we were not using Trastuzumab later on when we had limited options.
Yes, sir.
Dr.
Trastuzumab
Sekhri.
actually proven efficacy in xenotropic trial also. With Cape Trastuzumab also in second line setting after progression it has a proven benefit. The
Yes,
trial has been incomplete because of that.
So
and the combination with Trastuzumab, Lapatinib has also proven efficacy.
So I will give you the comment, what is written in the paper, which I don't agree, and I will take Krupa's comment. What they have written in the paper in HER2 climb is that they have given the reference of cerebral trial. But yes, the primary endpoint of cerebral trial was not PFS. The primary endpoint of cerebral trial was CNS metastasis. And I don't know why they have given in the discussion that why we have chosen Trastuzumab capecitabine. And they have tried to safeguard, but I don't agree with that statement that cerebral is the reference point. I also feel that maybe LabCap Trastuzumab was. So among all the panelists, how many agree that this is a weaker control arm? Okay, perfect. I mean, we are really going good here. Less of a... Sir, you also agree this is a weaker control arm. Thank you, sir. Thanks
And
for your
one
comment.
more thing with the
And
trial
yes,
design-
from the house also, we can take the comments. Does the house agree that HER2 climb is following a weaker control arm? We have the raise of hands. Yes. Wow. Okay, so point well taken, Dr. Amol. Any other concerns?
One more
Say
concern
something
is-
good about the trial, Dr. Amol. You will tell me good points. Untreated brain. Thank you, Senthil. 40%, 45%. 45% untreated active brain mets. Untreated plus active brain mets. Yes,
So
sir.
I would be happier to have
Yes,
a
sir.
1-to-1 randomization, no? Why would you do a 2-to-1 randomization?
Okay, sir. Fine.
If you
I
are
mean-
sure that you have a good product, no?
Okay, they had concerns. They had okay.
And one
So
more
there are
point
two
with the trial
concerns: 2:1 and a weaker control arm. Yes.
Yes. So another point to add regarding this is the number has been increased to secondary endpoint.
Yes.
They increase
Yes.
the
They increase the number. Yes. Thank you,
that is
Secretary, for that. Yes. Now TDX. Yes. Dr. Senthil, anyone? Krupa, you wanted to make
I
a
start
comment.
with this
Wait, Secretary. You wanted one comment. Sorry, I
I
did
think
not
you
take
and
that.
Unperson finished my comment, sir. You
Okay,
both
we can
finished.
start. Anyone? Dr. Senthil, anything? You
one
tell me
thing-
positive points about. Secretary, wait. Dr. Senthil, tell me positive points about DB03, and Amol, you tell negative, and then Dr. Secretary's comment. Only positive, or nothing positive.
It's all positive.
All positive. Control arm is perfect. Randomization is perfect. Primary endpoint is perfect.
Correct. For me, it looks
Only I have a problem with heading. Second line setting. I will come to that. I don't feel this is a second line setting. Dr. Amol, negative.
In the trial design, there is nothing, but it's
Yes.
about the post-progression therapy and that's
Oh, no. I said that we will read the paper as we read it. Okay. Say, Dr. Secretary, your
I have
comment.
2-3 things. One is they have screened around 700 patients for this study, and only 550 patients were randomized into the study design. Why 150 patient has been screened and not randomized is my first question. Second thing is they have excluded the patient who are metastases less than 6 months of trastuzumab pertuzumab therapy. They have not included into the study design.
Yes, I will
That is
come to that.
also-
I
is
will
there?
go there now. Okay, fine. I will go there. I think so. These are there is no cross trial comparison here, please. It is just
Sir,
I
one
put the
thing
table
is-
to table. Just
Another one thing is usually we expect metastatic breast cancer patient will have brain metastasis almost 50%. Here in the trial it is only 16%. That
Okay.
is also one
Okay.
thing.
Fine. Which trial we will have to see the brain mets here. It's not there in the table, I think. Okay. So we can start from Krupa. Krupa, your comments. Why I said DB03 is a third line trial. If you see the number of previous lines of therapy, one line is 41% and then the rest everything is 2, 3, 4, 5. If you concentrate on the right corner of the red table of DB03, so only 41% is going till 1 and then everything, majority have received 2, 3, 4, 5 whether adjuvant or metastatic. Yes, sir.
So at least, sorry, Kripa, you can make your point with that.
Please
Yes.
carry on.
Okay, fine.
So a part of the trastuzumab would have been in the adjuvant setting, not necessarily in the metastatic setting. So that's why you think it's a third line study. So, no. I'm saying this includes all treatment that the patient has received so far.
No, previous lines of therapy
It's
in
a
metastatic,
setting. Adjuvant they must have
that
received
is why I
before,
say
sir.
this is only 41% and the headline, the heading of the trial is second line and this is what is the approval is. So any comments?
No, but look at it
Yes.
like this. Look at
Yes.
the agents, Randeep. It's trastuzumab, taxane trastuzumab, pertuzumab, trastuzumab emtansine is less than 1%. So essentially, if you look at the agents
Yes,
that patients
then I
have
agree.
received,
Yes, I was about
so
to
think
make that
that's
point.
the way
Yes.
you should look
So
at
what
it,
is
right?
Dr. Senthil is making a point.
that's the way.
I also noticed
And it is well
that if you
balanced in
consider
both
that we all opted for regimen 1 or our choice 1, as per the choice 1, Senthil is absolutely right that after TCH or after the Cleopatra, this is exactly what you will do. The TDM has not been exposed. But another point is that this is not exactly what Cleopatra, they have not followed Cleopatra. Pertuzumab is 60%. So 40% have not even followed Cleopatra in DB03. And that's why I
because
left
of
that
access,
point.
multicentric, so
Fine,
access to
yes,
the
that
drug
is
and
what
so on and
is
so forth.
a slightly real body. Yes, say.
One more point I would like to add is
If you bring the real world practice,
Then it will be
across the
trastuzumab.
world, everybody doesn't get pertuzumab.
Agreed, sir. That's why I showed TMH data, which is actually the real world of the government setting or the public setting.
So
and
one
still
thing
the
is-
majority of the patients, yes.
one thing is age of the patient. So here the median age is 54 and they have taken patient from 83 years also. If they stratified the age group from 40 to 60 or somewhere the age stratification is there, it will be easy for us to use in our setting also.
Okay, fine. Point
And,
taken, but see,
one
okay,
more thing
fine.
to highlight between these two trials is it has more Asian population. It has more of Taiwan, Chinese and everything included. Whereas when HER2 climb study, it is less of a Asian population in the HER2 climb study.
Yes,
that
yes,
is also another
that is
point I
there.
would like to add.
DB03 is there. I think age will be slightly difficult to comment upon. We will leave that for the time being. But for the Asian one, I agree. So HER2 climb was a difficult population to treat. That is what the point I wanted to make. Pertuzumab was exposed in 100%. Trastuzumab was in 100%. TDM1 was 100%. Brain metastasis, we will come to it later on. And even in this table, 46% is the history of brain metastasis, active, inactive, active and treated stable, both were included. Any other comment from any panelist regarding the baseline characteristics?
And I think the most important thing is that in both the studies, both the arms were pretty much well balanced.
Yes, sir. These are actually.
That is the important take-home point. So whatever inclusion criteria abnormalities are there, balanced in both arms.
Okay. I think these were my comments. I have DB03. I think we have included. Yes. So this was another thing. I will ask this to Dr. Senthil. Senthil, this was one inclusion criteria. Are you comfortable with this? DB03 included patients who have disease progression within 6 months of neoadjuvant trastuzumab and taxane. So we used to put them on TDM1 and now they go to DB03.
That's right. So
you agree? I mean, that's okay. Fine. I just wanted to bring this point that this was one of the inclusion criteria. I'm not. It's not necessary that we always oppose or we agree. I mean, so DB03, both patients and investigators were not blinded, and the explanation given is, I don't know why they have given this explanation, and exact words are that both of them have used injectable and they were not able to blind it. I mean, TDM1 is injectable. Blinding is more difficult if they would have compared CAP-LAP with but this was not done. MRI as baseline was done in all subjects. So Dr. Indu, in your practice, and we take Dr. Safalta, are you doing baseline MRI for HER2 positive MBC provided that PET-CT was done? Let's be practical.
No, only.
I agree. I know PET-CT is not the test, and that's all I know.
No, but if the patient has symptoms, then only. Otherwise, I don't.
No, Dr. Indu, in your practice.
So routinely we don't, and actually, I mean, in fact, there is some data which says that even if you do MRI at baseline,
both these trials had inclusion criteria.
They have done, but actually, they say that the overall survival doesn't change even if you pick them early. Although.
Okay, but.
So
yes, Dr. Amol, MRI baseline.
No, in the routine practice we may not do it, but from the trial point of view,
for the trial point of view, because
they did it for everybody.
So actually, I read this point somewhere, and they say that this is a data-free zone where you don't know exactly whether every patient should get an MRI because ultimately things don't change much.
Okay. So another comment is, yes, sir.
Chase you for an MRI even if you don't want to advise it.
Okay, sir. Fine. So another point was, I think, anyone, Safalta, you have the mic, you can take it. Crossover was allowed after unblinding. This is HER2 climb. And this was done 14 months post-primary analysis, results were out. This is just you can make a comment, there is nothing negative, positive about it. This is just to be aware that crossover was allowed in HER2 climb. Okay. And was HER2 climb powered enough? This is for Dr. Amol. HER2 climb was powered enough for pre-stratified subgroups and CNS metastasis. Yes, no, don't know.
If it was not predefined, then I'll probably say don't know.
It was powered for the pre-stratified. 46% patients were there in the trial. Everything they had included. HER2 climb, I have to ask something so that Amol doesn't start asking me. That is the trick when Amol, Senthil and they are there. Okay, fine.
One thing with crossover, with the study design, they did some sort of censoring and 3 other statistics to overcome this crossovering.
Hardly anyone has crossed over. I will come to that separately.
That I would like to.
I will show you. Nothing has crossed over. Nothing has gone to. This is just like how the trials are done. I will come to that data. Hardly 9 patients have crossed over to Tucatinib in the whole data set. That is what I wanted someone to say. I will show you that the number. So I think nothing till now we are settled. We go to the results now. Both the trials, someone is having 28 months, someone has 29 months. I don't remember. I put both of them have a good follow-up. We agree that median follow-up is good. It is a clean trial. And this is a PFS, the primary endpoint, positive, hazard ratio is 0.33, narrow confidence intervals. And even the HER2 climb is 12 months, but we have a final overall survival data. I think no comments, we are agreeing that this is a nice clean curve and it is a practice changing curve. We also have OS data at the latest follow-up, 10% absolute advantage, hazard ratio 0.64, curves separating early, yes, events are happening till late. And this is the DB06 is the lower one, again a 10% advantage. Considering this advantage is that HER2 climb was a difficult setup to treat. HER2 climb was exactly third line. HER2 climb was something where brain metastasis was there and something which we had exposed the patients to Trastuzumab, Pertuzumab and TDM1. Yes. Yes, sir. Any comments among the results before we go to the, no, after that only we go to this subgroup, which is the dirtiest part of the trials. Yeah.
So I agree with your comments.
Fine. Anything? No problem.
The curves look good, but problem with the HER2 climb is that we know that control arm was not appropriate.
Okay,
but
fine,
for DB03, we are happy with the curves.
Okay, fine. It's fine. We have to interpret all that with the inferior control arm. Okay.
And other thing with
inferior means, I mean, see.
The word is suboptimal.
Okay, fine. So, Amol, you yourself have not adopted lab cap in your regimen. So you cannot make this comment. I asked every one of you that
we
whether
said
lab
lab
cap
cap
is in
plus
your regimen,
Trastuzumab.
and all of you said, no, my regimen is
No, it
TCH
was
followed by
there.
TDM.
It was there.
I think
lab
we
cap.
shouldn't misinterpret what people said. I think you spoke about
Lab cap will be the later on.
So I think
But
where you're
this-
coming from is the point is everybody assumes that lab cap is better than TDM1 for brain metastasis.
But we don't
That's-
have,
yes,
I mean,
so we don't
there-
have
we
evidence
know
to
the data, but
contrary
yes,
also.
we don't have a phase
And the
3
cerebral-
randomized data.
And the cerebral clearly showed that it was no different.
Yes, exactly.
So I think we haven't clearly shown that the TKI is going to be certainly better compared to TDM1 when it comes to the brain. And TDXD versus Tucatinib combination, if you cross compare, again the numbers look either comparable or better for TDXD compared to the Tucatinib combination. So I think that's the point you're trying to make. Is there a tendency to use a TKI if patients have brain metastasis? I think that's
Exactly, that is the crux. We come to that. That is the crux. We
think
will leave that comment here. Just we will come to the CNS metastasis.
Sir,
Okay, I think the age was.
shall I add a comment? One.
Yes, Sekri, please.
Regarding the Destiny 3 study design, even the control arm, the OS rate is, we should not do a cross-trial comparison, but compared to Emilia trial, the median OS is already crossed for the control arm also, which I would like to add. And the
Yes,
other
because
thing with,
that will happen. The trials are, the new drugs are being developed. The post-progression, they will receive something in the real world setting. That will happen over the decades. I mean, that there is a difference of around 10 years at least, or 8 years in the two trials. Emilia was, I think, 8
preferably
years
it is
before.
used in the second line setting only. It is not beyond that also. So that it is still same.
Okay. I did not get your point. The last point, prefer to use DB03 in the second line. No.
No, I'm making a comment like even that control arm having a better survival in the Destiny 3 arm. So they selected a very good population in the study.
Okay, the
design.
Amol has also made that
No,
comment.
I think that's not the interpretation. So when you're looking at comparison there, you should look at what's the PFS, because that's the primary endpoint, not look at the OS. If you actually look at the PFS,
Actually,
the
I
PFS
have
is
range.
a
I
tad
did not. Thank you,
lower
Doctor.
compared to what you get in Emilia. Right, in the Emilia, I think it was some 8.89 months or something. Here it's 6 point something. And the reason why it is 6 point something here is a lot of patients were exposed to Pertuzumab. And when you have Trastuzumab, Pertuzumab in the first line, and then you give TDM1 in the second line, obviously your PFS is likely to be lesser. So I think that's the fair comparison that you should make, not the overall survival, because as Randeep rightly said, you've got multiple lines. The DB1, the range of treatments that patients got were between 5 and 17. How many of our patients would get 17 lines of treatment for HER2 positive disease? So I think there are so many issues which will confound interpretation of overall survival. So here the fair comparison would be the primary endpoint.
And yes, please, I mean, we missed it, or this is a secondary endpoint. It's put on the slide. OS for both the trials was a secondary endpoint. Yes. Though it was met, but it was secondary. Subgroup analysis. Okay. All good. All good. Age is good in HER2 climb. Yes. All on the right except brain metastasis is, I mean, all good, but yes, I mean, fine, the brain metastasis numbers, and I think nothing to comment upon that. I mean, from my side, no, I mean, I have no comments and nothing specific. Yes, Safalta, you have something.
The patients who did not have brain metastasis, almost like Tucatinib, and both the arms were same across the unity.
Yes, that is crossing the unity. Only that is crossing the unit. But
Substantial benefit
that
is there in
means
the
if the
patient.
patient is not having,
any interpretation from this, I
so if
cannot
the patient
interpret.
is not having brain metastasis, there is no point of adding Tucatinib as a subsequent lines.
So you want to say that the systemic, you want to say that the extra CNS control of Tucatinib is weak.
No, it has
a
only
When Senthil, I agree with Senthil. I don't think so. We can interpret too much. Yes, Malhotra sir, and then Krupa.
Would you give importance to the hormone receptor positive patients, significant number of patients, and the hazard ratio is a lot less?
Sir, I made that comment opening that we agree this is an inherent, I mean the ER negative, HER2 positive is definitely a difficult disease to treat. And definitely I agree.
Forest plot, they have not given the p-value.
P-values and the pre-stratification, yes.
Probably we have to take it with some pinch of salt. But
yes, the p-values and pre-stratifications are not given, yes.
Yeah, and the standard deviation is also on both sides of the unity, so.
Only for sir brain metastasis, no, but most of them, okay, one is crossing for hormone positive. Yes, Sekri.
So one thing is,
I agree, good for all. Next, yes. Thank you.
So,
but we have a comment from Krupa.
Yeah,
no, Sekri.
Just want to conclude, all groups got a benefit, and patients who are having brain mets got more benefit. That's it. All groups got a benefit.
Okay, fine. I think I will have to jump to brain metastasis sooner or later. I have left it for the last.
So one thing is compared to hormone positive and HER2 positive.
You want me to go back?
And, yes. and when it is hormone positive and HER2 positive, neratinib is showing better benefit in this subset when it is in adjuvant setting. Whereas here it is not
we are
shown.
aware of that,
Or
but,
in Destiny also it is not like
neratinib
that.
trial in the metastatic settings have not shown a good OS advantage. So
But why it is shown in adjuvant setting alone? Why it is not here in these trials?
see, the disease is not different when you're talking about adjuvant and metastatic. We are talking about two
Neratinib
cross
trial is
trials,
Nala
and then we're
trial.
talking about two different.
It has to go to Nala.
Yeah, go
That's
to
what I'm
Nala.
saying.
Okay. Amol, okay, Nala trial has gone to Nala, so we don't discuss that, Sekri. Okay. Any, I mean, all towards the diamonds towards the left, baseline brain metastasis, that I will just tell that yes, even in the patients who have baseline brain metastasis, the hazard ratio is 0.54. Yes, so that is what it is, that in the patients who have baseline brain mets, so the numbers are less, DB03 is working as per the forest plot. Okay? Fine, fine. We come to the safety now. We have done with the results and we come to the safety. So grade 3 adverse events, 60% versus 51%. Of course, one drug extra has been added. I mean, it was Trastuzumab, capecitabine, placebo, and here it is. Tucatinib added to it. And discontinuation rates is almost similar, 13 versus 12. And I think that's it. And we also go to the toxicity data. I think, no, this is DB03. So DB03, grade 3 is 56 versus 51, around 5% difference to the control arm. Discontinuation is 21% in TDX versus 9% in TDM1. And that, I think these two are the major things. What are the, I mean, discontinuation I feel is the last, is the gold standard. If you're discontinuing the drug, maybe there has been a severe toxicity. But while we interpret both these overall safety summaries, we have to remember that the PFS difference is almost huge. So patients who are being on this test arm, that is Tucatinib or TDX, they are actually on these drugs longer as compared to the TDM1 or placebo. So that is to be remembered while we are interpreting the discontinuation rates and the grade 3 adverse events. Yes. Yes, sir, and comments.
And you have to be aware and highlight that with Tucatinib, you have to be careful about diarrhea, counsel about diarrhea, like you do for abemaciclib. And with TDX, you have to be alert about ILD. So those
Yes.
things.
Okay, fine.
Yeah.
So we will come to the.
You have to kind of highlight that.
So as per the safety analysis, the quality of life and others, it is tolerable regimen. That is what we look upon. When we are looking for new drugs, we are happy that PFS is there, OS is there. We have no concerns about the efficacy. So we now go look upon safety. I mean, just tolerable, yes. Okay, TDX has a safe, okay, fine. So the nature of side effect, which Hemant sir was pointing out. I am coming to it. Okay, coming to it. I'll go to ILD directly. Yes, this is what is this. They have used a term adjudicated to make the English difficult. Whatever they may say, ILD is there. It is 15%, don't go by this slide, what I wanted to say. ILD is not 5%. On a longer follow-up, this drug is toxic. The ILD, if you combine grade 1, grade 2, grade 3 ILD, God forbid you have, because after that you have to stop the drug and that means you are missing out on something if someone is developing a grade 3 toxicity on TDX.
I just wanted to ask
15% TDX. You have to
what is
tell,
the
you
real
can't ask, you have to tell here.
Yeah, what is the real world experience of those who have used it?
Okay, fine, that you can ask. Okay, someone who has used enough, okay, fine. So we'll take comments from Shyam sir. Sir is there because sir is the chairperson. Sir, all good for you, luckily. Okay. Anyone from the panel? Okay.
Beginner's luck, touch wood.
Beginner's luck. Okay, fine, perfect.
4.
Yes, Ullas.
Every 6 weeks.
And a PFT at baseline.
And PFT at baseline and a 6-minute walk test is what we do. So in a trial setting, we have got, when we did the Mariposa studies, we got grade 1, grade 2 ILDs, asymptomatic, just got the CT scan done. But the
Mariposa, we are talking about.
No, I'm just giving examples.
Achha, okay, fine.
So
fine.
I mean, in a TDM1 TDXG study also, you have to do the HRCT at everything. So you will pick up more grade 1, grade 2.
Yes, so you are right. I have only started in 2 patients. In 1 patient, he is heavily pre-treated, and I have done both the PFT and yes, Dr. Sailesh and first Dr. Sailesh and then Dr. Yes. It is later. Yes, thank you, Vivek.
We have done 6 patients in trial setting only.
Yes.
And, we didn't get any ILD We have done PFTs and...
But I think Dr. Sailesh has made a very important point that the median onset is 200 days, which makes it more than 3 months. So we have to still keep a watch, and even Ullas is also specifying that.
Both the agents are antibody drug conjugates. Why is one producing more ILD? Do we know?
Sir, because of the, yes, because they are not same. Yes.
Because of the
Anyone, Dr. Safalta, you can take it. Yes.
cleavable linker and the non-cleavable linker. So
yes.
if it is a cleavable linker, then in that case it can cause more side effects.
I think when they talk about that collateral damage, that the payload get released and a beautiful video when they show you, they don't show that when that payload get released and start damaging it, it can damage your lung parenchyma. I think among Tucatinib...
After grade 2 side effects, we need to start TDXT with ILD.
Sorry, come again, Sekri. Grade 2?
Even with grade 2 side effect of interstitial lung disease, we need to stop it.
You have to stop, yes. So even if you have a grade 2, you cannot re-challenge. And that's why I said, God forbid you have grade 3, because by the time you have grade 3, you're missing out on something. Grade 2, you have to stop TDX, yes.
And the onset is, median is almost 8 months for onset of AL.
Okay, HER2 climb. Okay, fine. HER2 climb, I think I have no exposure of using, I have not used Tucatinib. Anyone who has used Tucatinib, they can make a comment. Yes.
My patient prefers TDXD to Tucatinib.
Okay, okay. Anyone who has used Tucatinib and they can make a comment. Yes, your patient preferred. Okay, fine.
Yes,
The patient
so
who has
that's why I
received
said
both.
my patient preferred,
Okay.
not me preferring.
Chandrakant,
Correct.
yes.
No, so it is not only that, it's very similar to using Lapatinib. It's just a much more powerful Lapatinib. So the incidence of skin, incidence of fatigue, incidence of diarrhea is definitely much more, and it's not easy. It's not easy.
So we used Tucatinib in 2 patients, and we used in combination with TDM1. I think we have a recent paper of TDM1 with Tucatinib. The problem is TDM1 after 6 to 8 cycles of TDM1, you will have some bleeding that is happening. And this bleeding with this diarrhea, you have having GI bleed and low hemoglobin. This I faced in 2 patients which I have used. So there is this
bleeding
challenge.
from the gut.
Yeah, so there is thromboasthenia with TDM1. So that is quite often seen. So,
Okay.
So this is one challenge that you may face if you combine TDM1 with TKI.
I was thinking when these new trials come and the combination of TDX, they will change the world. Actually, they may change the world in the negative way also. I mean, giving 2 combinations, and I am aware that the TDX combination trials are also going on. So we come to the crux of the matter. CNS positive disease. Yes. No, I have not put the PFS2 data. But I have the subsequent data I have put it. The subsequent means the post-progression therapy data is there. So CNS positive disease is not a small number. If it is ER negative, it is 49%. If it is ER positive, 35%. So it's a significant number in the practice. We can't say that we will not face it. Once the patients are living longer, it is presumed that you will face HER2 positive breast in 50% of the patients. And this is, I will just read out the differences, or someone can comment, anyone, Krupa or Sekri, you can comment upon the differences between HER2 climb and DB03. Now we are talking just about positive CNS metastasis. The patient who has received Cleopatra and has a CNS metastasis, and we are thinking, or has received TCH as well as, we are in the 3rd line, and CNS positive mets, to keep the thing simple. So the difference is there in the 2 trial designs. Krupa, you will make a comment, Sekri or anyone, Dr. Amol. There is a difference. The HER2 climb, they included the patients who had active brain metastasis. Someone who had a more than 2 centimeter. Yes.
In HER2 climb, there are symptomatic brain mets are there. So the active brain mets are there compared to the Destiny Breast 3. Though the response rates were more appealing in the Destiny
No, I'm
Breast
just talking about inclusion criteria here. Yes.
Yeah, sir.
And Destiny Breast included active, but there was a big disclaimer that in DB03, if you are using active brain metastasis, they have to be treated. And 2 weeks gap, and when nothing happens, that is put, I think, here also in the slide, and then you can go ahead and use DB03. So DB03 was not someone who is having progressive brain metastasis, and that has not been managed by radiotherapy. And yes, Krupa, now this is DB03. To my mind, whatever we may say, the radiation was given or not, I just thought I will focus on the progressive disease. It is only 2.8% versus TDM1 22%. And it was not that radiotherapy was only given to the TDX. Radiotherapy was given to both the test and the control arm. But see, there is definitely a signal if you have 2.8% progressive disease. And with those patients who are living longer, till 28 months, we have the follow-up, which is a good enough follow-up. Dr. Indu, now you come here. Do you feel this data 28 months follow-up with radiotherapy being given, is TDX working in brain or not? You feel TDX is working? Generally, if we give only radiation and we don't give any active brain metastasis in HER2 positive, how long the radiation will work?
I was reading something and this shows that if you add like Trastuzumab also, if we talk about Trastuzumab also, then in brain metastasis, I think I'm forgetting what, I'll make a point a minute
Okay,
later.
fine, fine. Any comment from your side regarding regarding the CNS positive brain mets? How do you place SBRT versus whole brain RT in this whole discussion which is happening since last 20-25 minutes? Dr. Indu first.
So I'll make a, if you, I mean, then what it means is that if it would all depend, if suppose there is a patient with brain metastasis, then we'll see what is the prognosis of the patient, what's the performance status of the patient, and what is our intent of treatment. And then we'll have to see, of course, see the number of metastasis, site of metastasis, previous lines of treatments, systemic treatment, intracranial control, extracranial control.
Okay, so you have thrown the ball in medical oncology.
No,
okay,
no,
Dr.
no,
Senthil.
I
I got it. Yes, please complete your comment.
If the patient has only a solitary brain metastasis.
Let's say 2, 3, 4.
No.
SBRT amenable.
एक minute बोलने दो.
Okay.
So
sorry.
if the
My clock is ticking, sorry.
So if the patient has extracranial diseases controlled and there is a solitary brain metastasis and the patient is not having any large metastasis, no edema, then you can give only SRS. But of course, if the patient has brain metastasis which is larger in size causing compression effects, then surgery followed by cavity SRS. That would be the option to go. So if the patient has extracranial disease which is controlled and intracranial, there is asymptomatic metastasis, small metastasis not causing any symptoms, then you can continue with the same targeted drug. I will not be keen to add radiation. So, but if patient has extracranial disease also, extracranial disease is controlled up to 4 metastases, then I would like to add SRS, and then you can continue with the same systemic treatment.
Okay, Dr. Senthil. I wanted you to leave at that point. So 3 brain metastasis, patient is in 3rd line. SBRT, and now what? Would you like to change the regimen to HER2 climb, or you would like to continue TDM1?
If systemic disease is controlled, continue TDM1.
Okay, fine, fine. So that is the message. I just wanted someone, do everyone agree that right now we reserve it, or we, seeing this table, we are not getting carried away that the responses are good and there is a doubling of PFS in an SBRT. Of course, if someone has a multiple brain metastasis, I agree even with the, I mean, if someone has a multiple brain metastasis, I may shift. Even with the extra CNS control, I may shift to the HER2 climb. This is my take. But if 2, 3, 4 brain metastasis, SBRT done, I would continue TDM1. Yes, Hemant sir and...
Metastatic setting, 2nd, 3rd, 4th line, sensible sequencing is the buzzword, right?
Okay, sir. Krupa, any comment?
Certainly, sir. Like oligoprogression is the setting which you are discussing. So then better to like continue the same systemic therapy, not to change it.
Okay. Now I take a scenario that patient has progressed in brain also and patient has progressed outside the brain also. So we want a drug which works within the brain and outside the brain. I will just show you some data of DB03, and this is not DB1. This is DB1, DB02, DB03. Patients who have untreated active brain metastasis. The numbers are not great. The numbers are around 44 in the TDX and 25 in the comparator arm. And these are all the 3. Phase 1, DB02 was 3rd line, DB03 was 2nd line. This is the, these are all the phase 2 data and 2 phase 3 trials. And you can see there is a difference in 18.5 versus 4 months. So with this curve, now if someone has a brain, Dr. Amol, if someone has a brain metastasis and he has progressed and failed with multiple brain mets as well as in the liver and lung, still HER2 climb is the regimen to go forward, or you would like that TDX can cover and TDX is a better drug?
There is no doubt that TDXD is the better one.
So what will you do? Someone in the 3rd line is progressing, has been exposed to TDX.
If the patient is not exposed prior to TDXD, patient should be offered TDXD.
With brain metastasis also?
Yes, yes.
Okay.
Let
so
me
will
tell
you?
that after Trastuzumab, the next anti-HER2 blockbuster drug is TDXD.
With brain metastasis. Everyone agrees or no? Someone wants to contradict?
Yes.
So you feel that it is just with the inclusion criteria and that's with the statistics that this difference is being seen?
This pooled analysis.
No, Krupa, you go ahead. It's fine. Yes, please go ahead.
So since you decided to put the mic down, I'll speak. So Randeep, I think there are multiple small cohorts of patients now they have put together, and then the activity looks quite good, right?
Yes.
I don't think so. There's a trial called the Tuxedo study, which was read out
had
at
very less
ESMO.
patients, some 40,
Whatever.
40,
I think
50, yes.
prospectively it's not easy, isn't it? So at least the early results of the Tuxedo show that the response rates are not inferior. In fact, numerically it's better compared to what you would get with Tucatinib. And with such superb extracranial control, you won't see quadrupling of PFS commonly in oncology studies, right? 7 months becoming 28 months is very good. So with decent or good CNS activity, the CNS PFS is about 15 months at least in the DB03, which is at least numerically again better than Tucatinib, though again we'll make that point that Tucatinib is a much more difficult to treat set of patients. So there are so many things that are clearly now pointing towards the fact that both intracranially and extracranially TDXD might be a better drug compared to the TKIs.
Okay, so
and I think the tolerance is also now coming into issue. Of course, Shailesh rightly made the point that you will see the problems later, but at least as things stand now, it seems to be a good option to go to even in the second line, third line, whatever, as Amol said, as long as you've not used it.
6.4 minutes, Dr. Amish. So I will slightly disagree. You yourself said in HER2 climb, this is a clean data, single trial, 45%. Let me complete. You yourself said that in DB, the Tuxedo was phase 2, and then DB1, DB2, DB3, they have collated phase 1, phase 2, third line, second line. You yourself gave that answer that in the single trial, clear HER2 climb, 198 patients with brain metastasis. We will not have any other trial having such numbers in the future, I think.
So since I made that point, I'm reinforcing the fact that you have to decide based on what you have today. And with what we have today, with small cohorts of patients being put together, it clearly seems to be as good or even better than Tucatinib is what my feeling is. And that's the reason why I'm saying it.
Post-progression, Dr. We have 5 minutes, so I will have to go to the conclusion slide. Very brief comment, Dr. Mohul, you take it. Post-progression, this is your favorite. So you take this. Post-progression therapy, HER2 climb.
So there are 2 points. One is PFS1 and PFS2, and what is the increment of the control arm and the trial arm from PFS1 to PFS2. So if you see the control arm of the Destiny 03 trial.
Okay, I will put that first here, post-progression.
Yeah, and if you see that only I think 17% patients have received TDXD, but still there is a significant increment from PFS1 to PFS2 in the control arm of the TDXD, the Destiny trial.
Okay.
What it means in simple words is that, of course, if the more people would have received the TDXD after TDM1, probably the gap between the two would have been less. And what is clinical significant point for us is that probably we can say that if you want to sequence the drugs, if
we'll
you
come to
first
sequence.
have received TDM1,
that is the last slide.
But not the other way around.
Okay,
not
fine.
the other way around.
So and in HER2 climb, that is for Sekri. Patients who crossed over to Tucatinib, 26 out of 202, only 9 are on Tucatinib, 17 are off Tucatinib. So there has been very few crossover. It is okay, fine. So I think we have 5 minutes left and we will start. So life is complex. This is the current algorithm. This is what all permutation combination I could think of. And Dr. Senthil, you can start with brain mets, without brain mets, and we want comment from everyone, and this will be the last slide. It may take Dr. Amish 1 or 2 minutes, but this is the conclusion, because we agree these are practice changing studies. It is now about how do we sequence with brain mets, without brain mets. Dr. Senthil.
For me, with or without brain mets, sequence number 1 is the sequence to go to.
Okay, THP, TDX, HER2 climb, and then TDM1. And then fine, 5th line, and then fine. Hemant sir, with
because TDM1 works reasonably well if you have not given pertuzumab.
Pardon me, Chandrakant.
Pertuzumab not given.
So in the first line, sir, if you have not given pertuzumab, which happens with many of our patients, so in those patients second line, I think TDM1 is reasonable because.
So it's reasonable, but is it better than TDXD?
So Chandrakant, I will answer. Only 60% of the patients.
No, I think so.
60% only received in TDX. Pertuzumab. So it's a real world. I mean, in the real world also this is happening.
We are having too
much
of
wait.
Pertuzumab.
So TDM1 plus Tucatinib in second line.
Honest.
So Chandrakant, I think whether you've received pertuzumab or you've not received pertuzumab, I think clearly there is evidence in the second line to say that TDSD is a far superior drug compared to TDM1. Okay. As Randeep said, 40% of patients did not get Trastuzumab. And irrespective of whether you got correct. 40% did not get pertuzumab. And if you look at the split, and in terms of outcome, irrespective of whether you got pertuzumab or you didn't get pertuzumab, still TDXD was far ahead of.
So then TDM1 is gone in a metastatic setting, sir.
Okay, fine. So please, I will have to stop the discussion because this is the conclusion slide. We will not be able to take the comments. I don't want any explanation, sir. I just want your choice and regimen. We have done explanation in 45 minutes. I just want, what do you do now, Monday morning, Sunday morning, Ullas, Monday morning? Huh? What do you do? Ullas wants to know.
So if I have a patient on Monday,
sir, with brain mets, without brain mets? Yes.
Either I would do 0.2.
Because THP, TDX,
TDM1
TDM1 and okay, fine sir, fine. I don't want explanation. We just want the carry home message now.
I'll wait for Tuca to be available.
Okay, perfect sir. So 0.2 and if Tucatinib available then also sir 0.2. Okay, fine. Dr. Amol, with and without brain mets.
So there are very few drugs that
only answer, please. I'm requesting. No, please. No, it's no jokes about. I have left 2 minutes.
One.
With and without brain mets.
With without TDX1 is available, should be used upfront.
Upfront means first line. Okay, fine. Sorry.
Option 1.
Option 1, okay. Dr. Indu. I will get to you. Thank you.
Sequence 1, sir.
Okay, fine. So everyone is agreed for sequence 1 and I will have to go with the panel, though I don't agree. I may use in brain metastasis HER2 climb earlier and without brain metastasis I will follow option 1, but that is my take. I don't want to give any explanation here further now.
If the cost is not an issue, TDM1 is dead. Probably.
So we'll leave it to the experts that what do they adapt and to the chairpersons that I leave this slide here, only this complex slide, and take the comments from the chairperson and expert.
What do they say? After TDXD, how comfortable to use TDM1?
After TDX, we don't see for that matter, Sekri, I will answer. After TDX, how comfortable we are used to use HER2 climb, and after HER2 climb, how comfortable you are used to use DB03. The whole world doesn't know that. They are all uncomfortable. Any comments or any question from the house? Chalo, great. I think panel has done a wonderful job. Thank you. And over to Dr. Amish, sir.
We have no conflict of interest with TDX1, please.
No conflict of interest, yes. I think AZ people will go. I mean, they will have a special drink session tonight for this panel.
भैया हमने क्या गुनाह किया है? Only for this panel. Thanks, Randeep. Now can I invite Dr. Govind Babu for his expert comments?
First of all, let me start by thanking Dr. Purvish and Amish for putting this together. It's been a wonderful day so far. And Randeep has actually completed everything that needed to be discussed. So there's nothing to be discussed, but I'll just tell you a few things. You heard about Emilia and Destiny. A few things why TDX is better is because of the things that have been described as the drug antibody conjugate. So for Trastuzumab, for TDX it is 8.1, for TDM1 it is 3.6. And we also discussed about the cleavable linker. The cleavable linker is in TDX but not in TDM1, and the bystander effect because of this cleavable linker is seen with TDX. So that produces the effect as well as the toxicity. So that is what we need to remember. And for the Destiny B03 which was discussed, I think Randeep also showed the waterfall plot. And if you see the waterfall plot clearly, for the TDX, there were just 4 patients who did not respond. And they didn't even reach partial response. But for TDM1, it was almost 70 patients, and the cohorts were 200 plus. So those are important things for us to remember. And I think the intracranial PFS was also discussed for the HER2 climb. So I think when we talk about monoclonal antibodies not crossing the blood-brain barrier with brain mets, I think it's prudent that we realize that the blood-brain barrier is already broken because of the metastasis. And it's been shown that TDX has good intracranial activity as well. So as Senthil said, there is excellent extracranial activity and intracranial activity. So I think it's good that we use that whether there is intracranial disease or not. And this also prevents the intracranial disease occurring. So that's an advantage we have. I think that's all I had to say because Randeep has clearly finished everything that needed to be discussed with a wonderful panelist.
One last point I want to make, and I think after TDM1 and if the patient has received SRS, then the radiation necrosis is more. So we should keep that in mind, because if you do the MRIs of these patients, don't think that there is a that there is a progression. It could be radiation necrosis. So just keep the patients under watch.
That's why we always want to avoid radiation. That is the same thing that we discussed in ALK positive patients, because you cannot differentiate between the two. So as far as possible, try to avoid cranial radiation.
We can
Yes.
differentiate.
Exactly.
No, sir, we can differentiate whether it's a progression or a pseudo progression. So there are ways to do that.
Exactly. Yeah. Exactly. Thank you.
Thank you very much. Please come here.